Well, thanks very much. Yeah, thanks for inviting me down to these beautiful parts and the sunshine and all that. It's very good. You're doing it the right way, consent forms. We had a launch for one of our major publications yesterday in central London about girls in gangs, and it was only about 10 minutes before we started when I realised that Channel 4 were filming it, and I was told, to make sure people know about the media, and I thought, isn't there a process there? Shouldn't I say, if you're not unhappy with that, or sign a form or something? Anyway, I think we got away with it. I'm just going to set the scene. I'll tell you a tiny bit about me. I'm the Chief Executive of the Centre for Mental Health. A lot of you will know it as the Sainsbury Centre for Mental Health. Been going for 26 years, funded by Lord Sainsbury. We dropped the Sainsbury's name when he pulled the money about 3 years ago, but he gave us a very nice, generous final settlement, which has allowed us to develop a new business plan, bring income from elsewhere. So we're up and running. 4 years on, new business model is working very well, and we're continuing to develop and produce our publications. So all's good on that front. I'm going to set the scene and talk about the sort of latest policy and strategy issues around mental health. But firstly, I just wanted to say that I think for us working in mental health policy, we do feel quite optimistic at the moment. There are lots of challenges around, but we do feel optimistic, mainly that mental health seems to be getting a really good look in. It's enjoying quite a high profile. I feel it's quite a high priority. What happened last year in June when there was a House Commons debate, and Charles Walker and Kevan Jones and a couple of other MPs all spoke openly about their own mental health problems, led the way to much more openness about mental health issues, and it helped Times Change anti-stigma as well to get some momentum. And I think all the ministers and MPs at the moment and cross-party politicians seem to get that if you don't sort mental health out, then other systems and other plans that you've got for health, social care, criminal justice, whatever it might be, won't work very well. So you need to really pay attention to the mental health issues. So we're enjoying that. There's a group probably worth just telling you about. It's a mental health policy group, and that's senior officials from the NHS Confederation Mental Health Network. So that's all the mental health trusts across the country that have representation on this NHS Confederation network. Mind, Rethink, Mental Health Foundation, us, and the Royal College of Psychiatry. We work very closely together. We tend to dispute policy or try and amend policy and influence government together. And that's a thing that's been happening over the last couple of years. Years ago, we as organisations used to fall out and be very competitive. We're actually at one now, and we compete for contracts from time to time, but we do that in an intelligent way. And it's a good consortium of organisations trying to get sort of the better impact for mental health. It's important because the Department of Health mental health department has reduced considerably. There's not much of a presence in new NHS England on mental health. There doesn't seem to be much of a presence in the local area teams on mental health. It may develop, but there's a gap on policy and strategy, so we need to help fill that. The thing I really got to tell you about is parity of esteem. You'll know about it. Royal College of Psychiatry, Sue Bailey, the president of the Royal College of Psychiatry, and her colleagues have been driving this really hard, and it's really just it's very difficult to explain. Actually, we thought it was a great catchphrase, but we didn't describe it very well. It's really getting equality of mental health up to physical health in terms of investment, waiting times, outcomes, and other factors. So equality of mental health and physical health. Those of us that have been in mental health for years, we always said it was a Cinderella service. It didn't get enough investment, etc. But I remember running mental health services years ago, and child and adolescent services, where it's in the wrong room. Child and adolescent mental health services got hardly any investment at all. It all seemed to be very wrong. So the parity of esteem is to tackle that. It's serious stuff because it's got in. It's enshrined now in policy. The equality of care and treatment between mental health and physical health puts mental health on a par with physical health. And so there was a statement in Section 4 of the Health and Social Care Act, which you can read there, and the English Mental Health Strategy originally made the commitment in February 2012. So that was no health without mental health. Parity of esteem was plastered all over that. And there is a report out. The Department of Health actually commissioned the Royal College of Psychiatry. Don't know if you've seen it. It's worth a quick look. A report out on parity of esteem. What does it mean? Well, I mean, the key recommendations are parity of professional and public respect. I think a lot of us in mental health, well, there is a clear feeling in mental health that there needs to be work on that. And I think there's been, in terms of public respect, I think there's been a sea change in that. There's quite a way to go. Parity of outcomes, parity of care and treatment, and parity and integrated care. Well, I know you'll want to discuss integrated care a little later on, but I mean that's one way of addressing parity of esteem, is to integrate physical and mental health, and the systems in accident and emergency, for example, with psychiatric liaison service is a brilliant thing. You know, you have a psychiatric liaison team, community psychiatric nurse, or whoever it might be, in accident and emergency services, screening for mental health issues, picking it up and treating mental health problems quickly is obviously one solid way of integrating care. So what do we mean by parity of professional and public respect, tackling the stigma and the discrimination? And we won't progress an awful lot on mental health unless we really do try and tackle stigma and discrimination. The Time to Change team that Mind and Rethink run, funded by the National Lottery, actually what they find is when they go into healthcare settings, quite often there's a negative attitude towards mental health, negative attitude towards people in the workforce with mental health problems, more so than in other sectors within the workforce, even in mental health trusts, which is something we don't need to. And I sort of wasn't too shocked to hear that from my own experience working in mental health for so many years. So showing the same respect to mental health professionals as to professionals working in other areas of health, but you earn your respect. So we have a big part to play in mental health to talk about the evidence, articulate what mental health is all about, and do that in a very professional way, and then we'll earn the respect. Improving the attitudes of mental health and other healthcare professionals, people with mental health problems and their carers. And yes, there's I think having good employment practices and caring for your staff that have got depression and anxiety is of paramount importance. Parity of outcomes and preventing premature mortality. The NHS outcome framework should have an additional indicator that measures excess mortality in people with mild or moderate mental illness. And of course the research on schizophrenia is that you're more likely to die 20 years earlier than people without a serious mental disorder, schizophrenia or bipolar. That's pretty staggering, which would indicate that working on parity of esteem for outcomes is a good thing.
What is that related to? What are the causes of that premature death?
Yes, I mean it's a lot of sort of public health issues, smoking and obesity, the effects of drugs, the psychiatric drugs that are commonly given. I would say the sort of top three, and plenty of other factors, but and I don't know whether it's identified too clearly the exact causes, but they would be the three that often get talked about. The side effects of the drugs is clearly an issue, So there's an interesting. You talk to people in Mind and Rethink. There's a debate ongoing at the moment that there really is no place for psychiatric for drugs in psychiatry. It's about psychological therapy. It's about social care. A lot of people say, my colleague says, who's an international expert on employment for people with mental health problems, best form of treatment for somebody with mental health problems is paid work. It just reinforces the social indications of mental health and treatment of mental health. It's really important, and patients will tell us that what they want is somewhere to live. They want a job, paid work, and they want their relationships intact. Often what we think is medication, psychological therapy, and whatever else. So I think that's quite important.
Mental health is a medical condition, isn't it? And that's why it's not being treated socially. When it's been in our domain, I guess that's why we're treating it medically, isn't it?
Yes, that's right, exactly. And I grew up with that, and that's right. But the social factors are really effective and really important.
So is that a bad thing? Yes.
Is what a bad thing?
Is that it's treated as a medical condition with treatment?
I think it's all right I think it's all right to treat it as a medical condition. So it's all right to treat it as a medical condition, so long as you know there's definitely a place. I don't belong to the camp that says there's no place for medication in psychiatry. Absolutely rubbish. You know, I've seen it save people's lives, but I do think you must think about the social aspects, and you have to listen to what the patients are telling us as to better the way that they would perceive the treatment.
Sometimes the expense of these drugs, they're so expensive that maybe the money would be better spent, but the drugs are effective for
and I think there's a lot. That's right. I think there's a lot of work in that. The health economics of it all. We spent a huge amount of money on forensic care in this country. 20% of the mental health budget is on 4,000 people in low, medium and high secure services. And whenever you take a proper look at that, the health outcomes are pretty poor, and the system within forensic services is so inefficient. Someday soon we'll look at that and try to take some money out of that service if we can manage the risk and the risk to the public, and then put it in mainstream mental health, depression, anxiety treatment in the community. That's the sort of debates that are happening now. It's the sort of way I think things are going, and it's really important, isn't it, for commissioning, the world of commissioning, is to be thinking of these things. So palliative care and treatment, introduction of waiting time standards for secondary care, mental health assessment, diagnosis and treatment. So there's, waiting times for mental health is very varied. It's all over the place. It's quite common, isn't it, that people, the organisations that include child and adolescent mental health services say their waiting times are, months, sometimes years. So there's still quite a lot of issues around that. So I think how palliative esteem would work is we'd have to have a level playing field for waiting times, and monitor those waiting times and try to reach them. Parity and integrated care, addressing co- and multi-morbidity of mental health and physical health conditions. Commissions need to regard liaison services as an absolute necessity rather than optional. There's a report which I've just got the front cover up here, but a report on psychiatric liaison services in A&E. It got in the NHS operating framework as a thing to do. It's a good thing. Psychiatric liaison services in accident emergency. For every £1 that's spent on it, £4 is saved per year on an ongoing basis. So it makes economical sense. And there's now a lot of work going on in diabetic clinics, coronary heart disease clinics, whereby actually what's underlying is a depression or anxiety that needs to be picked up quickly. And you can only do that if you have a presence in those clinics. And that's being commissioned across the country. I'm sure you're doing that here. The next chunk that I want to talk about is recovery. I don't know if you know too much about recovery, but the mental health trusts, the mental health providers around here will be looking at recovery. It's the new model in mental health. I think I'll just go through the slides to explain it. Mental health problems do not just manifest themselves as a set of clinical symptoms, what we were talking about earlier. Recovery is about building a meaningful and satisfying life as determined by the person themselves. Whether or not there are ongoing or recurrent symptoms or problems. So the point is, whatever condition you've got, however severe it is, you can recover. And the definition of recovery would have to come from the person themselves. The key themes of recovery is agency, gaining a sense of control over one's life and one's illness. It plays into the debate we were just about to have. I remember sort of the medical model, if you like, very much involved in that. We take charge, we take care of the person's mental health condition. This is a change of dynamic. They take charge, they're in control of their condition, and we work in partnership to achieve what they require. The opportunity is building a meaningful life beyond illness. If you've got a depression or anxiety, even a serious mental illness, you can live a normal life, you can keep in work, it's good for you to keep in work, etc. Hope is believing that one can still pursue one's own hopes and dreams. And the relationship between a clinician and patient moves from being an expert patient to being coaches or partners on the recovery journey. So the implication of this is, for those of you in mental health in the room, the implication of this is radical and very exciting. And it will mean a careful look at the skill mix of large mental health foundation trusts a very effective way of providing a lot of this care is peer support workers, expert by experience, is patients themselves that have been through the system that are paid the proper rate to be part of the workforce. And the expert in the States on recovery said about 30% of your workforce should be peer support workers. And we're not saying that yet, that's too radical in this country, but there are recovery organisations across the country, and I'm not entirely sure whether you are one of them here. I'm sure you are. Yes. So you are looking at all this, and you're looking at peer support workers, and we're helping run our own part of that called IMROC, implementing recovery, and you're part of that. That's great news. And this reference here, Shepherd, Boardman and Slade. Boardman's a consultant psychiatrist that works for Jeb Boardman from the Maudsley. So really quite keen on this. So that's the implementing recovery. It's a cultural, it's changing culture, helping organisations change the culture to do recovery, as I've explained it, supporting organisations to change their whole way of working and thinking. If you're keen on it, there's this is all free to download. I can send loads of hard copies as well, but if you are a pilot site, then you'll have these. There's a publication on recovery colleges. So it's centres, usually within the mental health trusts, where you have a base where you can do some training on recovery and help people go through the stages, recovery, personalisation and personal budgets, and public mental health and wellbeing.
Sean, it's worth saying that local people, on the Devon Budget website, we've actually set up through Recovery College, the new prospectus has just come out, which has got lots and lots of courses which are accessible to people patients. You don't have to be part of the mental health system. So through Derek, perhaps I can
great stuff.
Get that.
So that's good. So the Recovery College is co-production between people with personal and professional experience of mental health problems. It reflects recovery principles in aspects of its culture and operation. And I just skipped to the last one, recovery, public mental health and wellbeing, an overall commissioning strategy that reflects the importance of mental health and wellbeing. There is, in that material, there is a publication on how you can commission recovery, which might be useful for you. I put this up because one of my colleagues that I spoke to said you're interested in integrated health pioneering sites. I haven't been able to, and you haven't either been able to find out the details of these yet, and I know you've got a discussion at the moment about these integrated sites that were announced a couple of weeks ago by Norman Lamb. There are 10 sites across the country, so we understand. He's very keen on this integration as a good thing, not just social care, but should include housing and police and employment. The principles are fantastic. And it's clearly necessary. It's a quick chat I had earlier on that we've been trying to integrate health and social care, for example, for many years now. Now, if there's a retrograde step because of the new changes, well, that's not necessarily a good thing. So we've got to think of ways to get over that and to motor on integration. Because the stuff I've been talking about, you can't do it unless you've got sort of integrated provision and integrated commissioning. And health and wellbeing boards, when we were looking at the health reforms, I thought the health and wellbeing boards were going to be a really good thing. I thought they were going to have clout and teeth, and they were going to assist local health communities in pooling budgets, creative ways of doing proper joint commissioning between health, social care, employment, criminal justice, housing, what have you. But I think we're a long way from that. And I'm not entirely sure how the health and wellbeing boards are going to be held sort of to account for that. You might know more yourself because you'll be relating to the health and wellbeing boards, but it was a concern that we had because we do a lot of work on really vulnerable groups like offenders with mental health problems in the community, and they've got complex problems that all agencies need to be involved in, particularly when you're talking about children. And offenders with mental health problems. It's education, social care, healthcare, police, all the criminal justice services. There's got to be a way of bringing all these agencies together. We had thought that health and wellbeing boards might be the vehicle to do that. So just keep an eye on that because it sounds like they may not be. So we've sort of come up, this is our own, from the Centre for Mental Health, if you like, our own in terms of the evidence. There's a lot of evidence around IPS. It's individual placement and support. It's for employment for people with mental health problems. every mental health trust should have an IPS employment service. A lot of mental health trusts do. Typically in a community mental health team, you would have an employment specialist. So people with mental health problems would be able to get paid work and be supported to staying in work. It helps everybody. The IPS model, if run properly, repeated trials suggest that 60% of people with a serious mental disorder can stay in work for over a 1 year period. So it's pretty good results, really. Liaison and diversion services in every police station. So this is the Bradley. You'll know about this. It's important to mention it, actually. So you probably heard it as sort of the Bradley investment. The Bradley Review. Lord Keith Bradley is one of our trustees. He wrote the report 3 years ago that said that one of the main recommendations is that every police custody and court should have access to mental health, liaison and diversion by 2014. And there's £19 million in the system at the moment, and there needs to be £50 million for that to be achieved. It's still not enough. It's, you know, £50 million, but it's a lot of money, given that there's no new money around at the moment. The only new money around is psychological therapies and diversion. So I think, again, from a commissioning angle, it's just you need to know that this money's around. Now, there's a business case at the moment. Sorry, I've got 5 minutes. That's great. Good timing.
I'll let you know.
Yeah, thank you very much. I was supposed to be seamless, wasn't I? I was supposed not even to notice that, but I'm nearly done. The £50 million is a business case at the moment to convert the 19 million into £50 million. There's a little bit of worry that there's some politics going on, and the rest of it, we're told the rest of it will come out into the system.
Surely not double counting.
No, there'd be no double counting. But as this is new money, it just gives commissioners an opportunity to tackle offenders in the community and to provide services within the courts and police services. But it just gives you just that extra bit of money that you can use creatively and try to get some good commissioning models. I understand that there's NHS England have appointed 10 commissioners for offender health across the country. You'll have one here. Whoever it is, it's worth speaking to, because they'll have the money over a period of time. And I mean, it's really good stuff. And we've been doing quite a bit of work on this, and all over the country there's some really excellent models of good diversion, including children and young people. This money goes to children and young offenders as well, so they have an assessment very quickly. Problem is, the £50 million will allow the assessment and some treatment, but it doesn't allow for diversion to what? If people need extra acute inpatient beds or need step-down facilities from psychiatric low-secure units, well, it won't cover that, but it's a very good start. So I've finished now. All these are free to download from the website, and the long-term conditions and mental health I think that might be quite useful. So it's the integration, the interrelationship between long-term physical conditions and mental health, and what recommendations, what the evidence says about some recommendations to tackle that. Recovery colleges, in the middle there is a chance to change. It's a study of children with conduct disorder, a recognised mental health problem. 80% of adults who commit a crime have had a conduct disorder as a child, largely untreated. The evidence is provide parenting classes, parenting skills, and you can do really wonderful stuff to prevent people from having a conduct disorder to a full-blown personality disorder later on in life. This is all about early intervention. Probably don't do enough of it in this country, but it ought to be there. And doing what works is a study about employment for people with mental health problems, and it describes what I was talking about, IPS, individual placement and support, and that's the report on liaison psychiatry in the modern NHS. So I've got time for questions.
You have?
Yeah.
You have. Any questions for Sean?
On the previous slide, you had, I don't think you need to go back, parenting services, but you didn't even mention it.
No.
And time after time,
Yeah.
I think we all meet people who turned out mother, father, somebody
Yeah.
else in the family had a mental health problem when they were younger, maybe unrecognised,
Yes.
and they themselves are suffering from mental health
Yes.
problems. Isn't that an area with huge potential as well as your
Yes.
conduct disorders. I mean, isn't
Yes.
that where the
Yeah.
next generation of people with mental health problems are coming from?
Yes. Just say, do you mean the children or the
I
parents
mean,
of
the
the children?
children of people with mental health problems,
Yes.
the children of those
Yes.
offenders,
Yeah,
the children
absolutely.
of the people,
Yeah.
it sort of seems to be escalating.
Yeah.
And I'm not suggesting we neglect those people who are suffering, adults with mental health
No.
difficulties, but we can't forget their children.
No, absolutely not. And there's not enough.
No.
There's not enough services in this country for it, but some of what I've talked about would indicate that that's what we need to do. You know, we absolutely need to do it. So schools and the educational system needs to be better equipped for identifying vulnerable children at an early stage, and and often it will be that their parents have got mental health problems or substance misuse problems, or just are not good parents, are really bad parents for whatever reason. And parenting skills there's quite a few of them around. If they're done properly, they have amazing effects, for better life chances for children. And obviously, if they're equipped and you during that program you identify that the parent themselves got a mental health problem, then that needs to be triggered and referred on to mental health services. But yeah, you're right.
No, it's Turkey, of course.
Can I go back to your point about the parity of esteem
Yeah.
and that figure that you said about the excess mortality and
Oh, yes.
reduced life expectancy? Well, I knew it was significantly different, but I didn't realise it was quite that bad.
Yeah.
And the thing about the drug therapy, can I just ask, is the drug therapy factor, is that increasing or reducing? I mean, there's more and more complicated drugs and more and more, side effects, isn't there? Is that getting worse or getting better?
I don't know for sure. Does anybody know? I don't know. My sense is it's not getting any worse, not getting any better. It's the same. That would be my sense
It's
of
just
it.
a feeling that there's more and more complicated.
I know that there are.
And we know less about them.
Yeah, I know. But in the past we were giving drugs, major strong drugs that we didn't know an awful lot about, with terrible side effects as well. So that sort of probably balances out. That 20 years is an underestimate. I mean, the States is saying much more, 30 years, 26 to 30 years. But it is, the most recent study was at the Maudsley Hospital in London that came out with the 20 years for this.
Just from the mental health side, I think we've got much better at having shared care agreements and understanding some of the physical health needs of some of the people that are having complex trauma. We also get better at prescribing better dosage, less polypharmacy, less crazy dosages. So there's a lot of work that's going behind that to work between primary care and secondary mental health care to try and work on that. And we're not there yet.
No.
There's lots of work.
I think we're aware that in the last 2 years there's a huge amount more with letters from psychiatric teams that, about keeping an eye on this, keeping an eye on that, checking cholesterol's, doing this, blood pressure. Because that's, it's been sort of much more widely recognised now, hasn't it? I mean, I think
That's
they've
right.
known about it for a long time, but the discrepancy and the
So
sort of,
all that's really
life
good
expectancy
stuff.
has really been sort of,
Yeah. It's good. It's good. And primary care's a huge role in that. It's good.
Quick question. I was really pleased that you touched on the impact that mental health specialists can have on long-term condition work, particularly in general hospitals.
Yeah.
And we're, I think, quite frustrated by the knowledge that we can have a significant impact, and there's really good evidence now of a significant impact on people's use of secondary physical health resources.
Yeah.
But actually, the way that commissioning is arranged, we have in the county, we have 4 big sponges, which is the general hospitals, which soak up a huge amount of the healthcare funding budget. And what I wanted to know, Sean, is whether any debate is happening that you're aware of how we actually lever some of that resource towards mental health intervention for those people. Because the problem is that what can easily happen is that it's just out of the relatively scarce mental health resource. We're being asked to do more and more and more, and whilst at the same time knowing that we really could, if properly commissioned to do it, have a significant impact on those other general health care pathways.
That's quite good. Last on the line, it's quite good. You know, what we know about it is in the detail of that, and it all comes from RAID, the RAID model in Birmingham.
And I know.
And what they did, as you know, is that they did pull money out of acute secondary care. They pulled it out of the savings from bed days in acute secondary care, mainly elderly, frail people that with proper psychiatric screening didn't need quite so much, but there's a reduction in bed usage. So they pulled the money out of that. There was pump priming to begin with, and they're pulling money out of that.
I know, it was 2 million pump priming. I mean, you know, but I think, I guess what I'm asking is, are you aware of governmental level discussion around this?
Yes, I am, and you know what the answer is going to be. The government answer is, good luck. Here's the model. Read that, and good luck. Do it locally. I'm sorry, but it is. That's what they say. Yeah, and that is really what they're saying.
So with the new system, do you think there's a chance of all the agencies speaking to one another better?
Well, I think so. Yeah, I think so.
Yeah, so perhaps that's a great segue to the next bit, which is thank you very much, Sean.
Yeah.
Thank you.
That's
Leave them wanting more. That's what I was saying.
No, that's good. Yeah, that's very good.
And